Let's talk lungs with Trent and Lori from Lung Saskatchewan. Dedicated to connecting you with lung health experts and key opinion leaders who will share current evidence-based lung health information to inspire you and those you care for to take your best breath. This podcast is recorded on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, as well as the territory of the Métis.
On today's episode of Let's Talk Lungs, we're joined with Dr. Mohit Bhutani. Dr. Bhutani is a professor of pulmonary medicine at the University of Alberta, where he also directs the asthma and COPD clinics. He's recognized nationally for his leadership in respiratory care, research, and education, and has been a long-time contributor to the Canadian Thoracic Society guidelines.
This episode of Let's Talk Lungs is proudly sponsored by the Saskatchewan Health Research Foundation, also known as SHERF. SHERF invests in health research that makes a difference right here in Saskatchewan. Learn more at sherf.ca. Dr. Bhutani, thank you for joining us today. You're certainly a dear friend and colleague to us at Lung Saskatchewan. But before we get into science and therapies around COPD, can you tell our audience a little bit more about you? Why did you choose medicine, and what led you specifically into pulmonary care?
Well, good morning, good afternoon, Trent and Lori. Thanks for having me here today. It's a pleasure to be here with you. I've certainly enjoyed working with the two of you and Lungs and SAS Lung over the last several years. And before I even start, I just want to congratulate you on all the great work that you're doing to help improve and transform pulmonary care, both regionally, nationally, and honestly, internationally. The work that you do has long reaches, and I'm always appreciative of help you guys help change pulmonary care. So thank you for the invitation today. It's a good question. Medicine, I've been in practice for 20 years, and I've been in medicine since 1994. And when I was growing up in Saskatoon, I had a lot of friends whose parents were physicians, and I sort of got a chance to see the kind of work that they did and the impact that they had, on the community. I had a natural interest in the health sciences. I enjoyed anatomy, I enjoyed physiology, pharmacology, and I was really sort of saw medicine as being an avenue where I could combine all of those interests into one area. And the concept of being able to help patients through people through your work really was something that attracted me, because I wanted to make sure that whatever I did in life left an impact, whether it was to an individual or to to a larger focus. But I wanted to have some sort of impact out of my work, and medicine really afforded me that ability to do that. And so I was fortunate enough to get into the University of Saskatchewan and complete part of my training there. Pulmonary medicine was an interesting one. It was actually Dr. Darcy Marciniak, who, as you all know, is a very prominent respirologist in Saskatchewan and around the world. He gave our class a lecture in the pulmonary block of our systems rotations, and it was on COPD, on the acute and chronic management of COPD. And he was just a very good educator, and he left me really intrigued as to the disease and to what we can do about it. And then I just started to explore pulmonary medicine a little bit more, because obviously there's more to pulmonary medicine than just COPD. And what was really interesting about it was that everything affects the lungs, right? So whether you have heart problems, or you have kidney problems, or you have gastrointestinal problems, there's some manifestation of it within the lungs. And as you choose a subspecialty career, what was intriguing about pulmonary medicine was that I would retain some of my general internal medicine knowledge, and that's really come to play. That a pulmonologist really needs to know a little bit about everything about the body, because it does affect the lungs. And so from that, along with the physiology that is very interesting when it comes to pulmonary medicine, those are probably the two big things. But importantly, I think the people that I got to work with in Saskatchewan, as I decided to, maybe pulmonary medicine is where I wanted to go, I found a kinship with the practitioners, that they're just level-headed individuals who have a common good in mind, and that really work hard to try to help improve the outcomes for their patients. And I think there's just a relatability to pulmonary physicians that I got to know, and that has really stood the test of time here.
Can you give us a quick overview of COPD? We want to even the playing field here, and so just maybe talk to us a little bit about principal cause and diagnosis.
Yeah, that's an important question. So COPD, or chronic obstructive pulmonary disease, right? It is an inflammatory lung disease. Inflammatory lung disease that's primarily driven by what's called neutrophilic inflammation, and that inflammation results in sort of damage to the lungs along the airways, and then to the microscopic parts of the lung where gas exchange happens. So where oxygen goes in and carbon dioxide comes out. And so it's that chronic inflammation that results to the long-term damage that we experience with the lungs. The number one cause that leads to the development of COPD still remains tobacco exposure and cigarette smoke. But over time, as in the developed world, especially where prevalence of smoking has gone down, there are other causes that have come to light that have contributed to the development of COPD, which include pollution, so both indoor and outdoor pollution, occupational exposures to the development of COPD, such as farming and the oil and gas industry, and then there's some genetic conditions. The one that sort of is the one that we know most about is called the alpha-1 antitrypsin deficiency. And so, a number of different causes that can lead to the development of COPD, but still globally, the number one cause remains tobacco exposure. The diagnostic portion of it is that we need to use a lung function test called spirometry. Spirometry is a test that you may have heard of. It requires, it's often known as the blow test. And so it's, where patients take a big breath in and they blow it all the way out. And there's certain physiological parameters on the spirometry that ultimately leads to the diagnosis of COPD.
Dr. Bhutani, is COPD becoming more common in Canada and around the world, or is it just that it's increasing, or is it that we're getting much better at diagnosing it? And what trends are you seeing?
Yeah, so that's a great question. So there's a couple of things on this. With COPD, because we need spirometry to make the diagnosis, access to spirometry, in Canada and around the world is quite heterogeneous. So in some places it's very easy to get spirometry, in other places it's very challenging. So there's a huge sort of unmet need when it comes to COPD in terms of diagnosis, because there's belief that almost half to up to depending on which reports you read, about 80%, 50 to 80% of patients with COPD remain undiagnosed. Okay, so there's the statistics of the people that we do know, and then there's this whole unmet need of the undiagnosed population, which it needs to be found. But globally, yes, the prevalence is increasing over the last number of years, and this includes even in Canada. And what's challenging with COPD is that it's burden on the healthcare system. So there's lots of good data to sort of show that over the last 20 to 30 years that COPD flare-ups, so exacerbations or lung attacks, as they're sometimes called, often are the number one cause for hospitalizations in the country with long lengths of stay. And that's it's an outcome or a data point that we have not been able to move very significantly in the last 20 years, despite the advancing knowledge of COPD. And that's probably a little bit due to the rising prevalence and then patients presenting themselves with more advanced disease because of that unmet need of the undiagnosed population. There's a really nice report out of the Canadian Medical Association Journal, about 2 years ago, that sort of looked at hospitalization rates for COPD compared to all other causes. And what it showed over a 16-year time span was that all other causes for hospitalization, the trend was going down over that 16 years, whereas COPD, remained about the same and debatably started to rise over that same 16-year time span. And that, that goes from 2002 to 2016, 17. So, the data is very consistent that the COPD has a massive impact on our healthcare system. And as well, it does have a significant impact on our patients, most importantly.
Dr. Bhutani, can you talk to us a little bit about risk factors for the development of COPD? Why, for example, wouldn't everybody that smokes develop COPD?
And that's the $1 million question, isn't it, Trent? That, you sort of take a look and say, all conditions, I think in medicine really there's a genetic predisposition and an exposure that probably allows you to develop the disease. So, as I said before, smoking is still the number one cause for the development of COPD. But there's got to be some sort of genetic predisposition probably for the development of the disease within the lungs. The other factor is that the amount of tobacco consumption can vary a little bit, right? So we say that, smoking 1 pack a day for at least 10 years puts you at the sort of an increased risk of the development of COPD. That's kind of the minimum exposure. So the amount of tobacco you consume, do you smoke the whole cigarette? Do you consume a pack, half a pack? Those sorts of factors develop and will likely play a role in the development of the disease. And then there's the other components, right? We talked about the occupational exposures, the environmental exposures, and then the only genetic predisposition that we know of is the alpha-1 antitrypsin deficiency. But what we're understanding, and there's lots of good research going on in Canada and around the world to understand the different types of COPD that exist. And my understanding of COPD is continuing to evolve, over the last 20, 25 years of myself being in this profession. And so our understanding of that development certainly needs to be further understood, and there's research going on in that area.
The Canadian Thoracic Society, or CTS, guidelines for the management of alpha-1 antitrypsin deficiency have changed recently. So can you walk us through what that is and how it relates to COPD?
Yeah, that's great. Thanks for highlighting that document. So my colleagues at the Canadian Thoracic Society, which is really the largest professional society for pulmonary specialists, so both physicians and non-physicians involved in the pulmonary space, published this guideline. And there's a couple of things about the guideline. One, there's a very strict and sound methodology as to how the guidelines are developed at the CTS. So when they publish something, that it's the best evidence has been incorporated to give the best opinion on how to diagnose and manage the disease. So a bit of a shout out to the CTS and their processes. The guideline itself has really sort of has changed the narrative on how to approach the screening, and then ultimately help guide the treatment for COPD. So the guideline says essentially now that anybody at any age diagnosed with COPD should at least have one test to see if you have the genetic predisposition to COPD, which is alpha-1 antitrypsin deficiency. So just to take a step back, what is alpha-1 antitrypsin? It is a molecule in the body that helps control inflammation. And when you're deficient in it, even if you don't smoke, there's a chance you can develop COPD. If you do smoke, then there's a magnitude higher likelihood of you developing COPD. So knowing if you have this genetic predisposition is important. For one, there are treatments available for you that can help address the alpha-1 antitrypsin deficiency. And then two, as a genetic predisposition, it's important for family planning and relatives and that sort of thing to sort of make sure that that everyone in the family understands that there's that risk and that they maybe need to look for alpha-1 antitrypsin deficiency within themselves as well. So the guideline suggests that everyone should get screened. The reason being is that the blood test that tells you whether you're deficient or not is a very low-cost, high-yield test. It's just a few dollars, and if you're deficient in it, then they recommend to go on to genetic sequencing, which tells you if you have what types of genes are involved in the fact that the alpha-1 antitrypsin is not being produced properly within the body. The reason why that's important now is that if you have certain genetic predisposition, the alpha-1 antitrypsin replacement is now generalizably available across the country through Canadian Blood Services. So that's a very important change that's happened in Canada. And in fact, we're the only country that does this through the Canadian Blood Services, that the treatment is funded. And it's a massively important step. And we're actually considered to be leaders in the world in terms of how we support and replace alpha-1 antitrypsin deficiency. So a treatment that was at one time very unaffordable for the masses is now ubiquitously available across the country through Canadian Blood Services. So the guideline is actually very, very relevant given the change in the funding model for alpha-1 antitrypsin replacement, because if we screen it, we see it, we could, and you are deficient and you have the appropriate genetics, you can get replacement, which has long-term benefit to the patient.
Well, Dr. Bhutani, let's use that as a bit of a segue into the next part of our conversation. Treatments available in Canada for COPD, from inhalers to when oxygen might, come into the equation, and then even some of the newer things that we're hearing on the horizon.
Yeah, so that's great. So, I was one of the authors of the Canadian Thoracic Society 2023 COPD pharmacotherapy guidelines. And so the way that we sort of approach the management of COPD is we divide it up into the non-pharmacological, so the things outside of pharmaceutical treatments, and then there's the pharmacological therapy. For the listeners, the one thing to know as you approach the options for therapy, in our guideline, we are very clear that there's an important assessment that needs to be made of the patient, and every patient needs this assessment to be done. And so this includes using lung function, using the Modified Medical Research Council dyspnea scale. So that's the scale that goes from 0 to 4, 0 having breathlessness with strenuous exercise, to 4 having breathlessness with activities of daily living. Then there's also the COPD assessment test, also known as the CAT score. It's an 8-question questionnaire on a Likert scale from 1 to 5. That the higher the score, the worse your quality of life. And if somebody has COPD, a CAT score of greater than 10 is considered to be an impaired quality of life. And the last thing is looking at a patient's future risk of exacerbations. So that's based on their 12-month history, the 12 previous months of their exacerbation history. So if they've been treated as an outpatient with antibiotics or prednisone at least 2 times, or been hospitalized for an exacerbation of COPD in the past 12 months, that would be the divider. So 2 or more outpatient, or 1 severe, you're high risk, and if it's less than that, then you're considered to be low risk. So you put those variables into the mixer, and then based on the thing that puts you at the highest risk, then you have to take a look at the different options of therapies, both pharmacological and non-pharmacological. So there's a huge menu of options for therapy. So focusing on the non-pharmacological first, the one thing that we sort of done, and Dr. Jean Barbeau, who's the lead author of the 2023 guidelines, published a very salient paper, more than 20 years ago, looking at self-management. It's really working with the patient to educate them and to make sure that they understand the disease and what they can do as partners with you in their disease treatment and their trajectory. I think applaud again Sasalan for all the good materials that you put out there for patients to use. So those kinds of informations and that kind of relationship for self-management is really critical to help patients have the best outcomes that they can have. So there's self-management. There is the use of vaccinations. I think some people use the term the Fab Four. So there's the flu vaccine and the pneumococcal vaccine, which we've been advocating for many years. But in the last couple of years, there's the RSV vaccine that has come to play. So as developments happen in the pharmaceutical world, and you start to look at the impact that some of the treatments have and the benefits that they have, you realize, wow, these are really important treatments to come along. RSV is an important virus that I think we had not a lot of options for treatment, but we now have an option for prevention, and very effective prevention with that vaccine. So we encourage our patients to get the RSV vaccine, because there's a fairly significant prevalence of RSV leading to exacerbations of patients with COPD. So we encourage that one. And then obviously COVID is the other vaccine that we encourage our patients to do. During the pandemic, we recognized that patients with underlying lung disease asthma or COPD, they tended to have more severe complications of COVID. And so we certainly encourage our patients to get the COVID vaccine if they can, depending on which province I suppose you live in and what the access like that looks like. And then lastly, the one I always like to add in a little now is the shingles vaccine. It's one of the vaccines that have sort of, as it's come around and we understand its impact with patients with COPD, after a flare-up or an exacerbation, there's a fairly high preponderance of reactivation of shingles within COPD patients. So I do have that discussion with my patients as well as to the vaccinations. We certainly promote exercise and pulmonary rehabilitation. I think pulmonary rehabilitation, although access in the country is variable and can sometimes be limited, in my opinion, is that this is a cornerstone therapy. I think it's as effective as any inhaled therapy or any other therapies that there are with COPD. And I think the understandings and the learnings of the disease and the exercises that we know can improve long-term outcomes for patients with COPD. In my opinion, it's not a discussion of you should go. You must go, I think, is the concept when it comes to pulmonary rehab. And then we go into the pharmaceutical treatments. Lung medicine is very much dependent on inhaled therapies. And so long-acting bronchodilators, either in combination with inhaled corticosteroids, really form the sort of the treatment paradigms for patients with COPD. And then there's algorithms that we have based on this disease severity that determine which inhaled therapies are appropriate for patients at what point in their disease.
Before we take a short commercial break, we have one more topic we'd like to throw out on the table. So at LungSask, our healthcare community and our patient communities are certainly asking a lot of questions about cannabis. So Dr. Bhutani, is there any evidence linking cannabis to COPD or other lung harm?
Great. So that's a good question. This is the tough one to answer because it depends on what you read. There's no undoubtedly cannabis has an impact on lung function, and so there is a bit of an impact on lung function when somebody consumes or inhales cannabis. The question for, I guess, does it actually lead to COPD? So right now, the data is a bit challenging to go through because behaviors often overlap. So patients that inhale cannabis often also inhale tobacco. And so the question is, is it the chicken or the egg? Is it one or the other? Is it a combination of both? So I think that's the one thing that it's hard to know. We know there's an impact on lung function, but is the impact significant enough to lead to a long-term trajectory where you develop the physiological parameters of COPD that is needed for the diagnosis? And so we don't really have a clear answer on that at the moment. I think there's likely an effect. It's probably additive, but because of the heterogeneous nature of how people consume cannabis, it's hard to know if it in and of itself is a direct, cause of COPD. Is it a loss of lung function? Yeah, I could say absolutely likely has an impact on the loss of lung function, but is it a loss of lung function significant enough to lead to the exacerbations, to the development of COPD is a bit debatable. The Canadian Thoracic Society is right now working on a guideline on these questions, and I think they're going to do a deep dive in the literature in terms of trying to fully understand that. And in about a year or two, I'll probably have a bit more evidence-based, guidance on terms of what the true answer is with this.
Lung Saskatchewan has long been associated with leadership in lung health education. Whether you enjoy webinars, videos, printed resources, or podcasts like this one, we're here to support your best breath. Learn more at lungsask.ca.
Well, Trent and I are back today with an old friend of ours, colleague, Dr. Mohit Bhutani. We're so delighted to be having a conversation with him about COPD on Let's Talk Lungs. So let's continue where we left off before the break. What about vaping? Are we seeing emerging data about its impact on lung health and COPD risk?
Yes. So this is, if you ask most respirologists or anybody in healthcare at this point, I think that's one of the biggest concerns that we do have is the rise in the prevalence of vaping. And the last report, it's been a couple of years since it's been assessed. In Canada, the number of people, and particularly youth, who have tried vaping at least once sits in the 40 to 50% range, which is just unbelievable, right? And so the worry is that this becomes a gateway to tobacco consumption along the way, in the sense that you can concentrate as much nicotine as you want in the vape oil. Eventually there's going to be an upper limit to what you can do, and that's going to be a gateway to tobacco consumption. So massive concern in the healthcare community about the rise of vaping, especially in the younger population. And there's a couple of reasons for that concern. One is, as you asked the question about its impact on lung health. I mean, I think the data about its impact on inflammation in the lung is very concerning. It mimics and probably, is even more severe in terms of the inflammation that leads to COPD that is driven by tobacco smoke. So I think that's one fairly big concern from that standpoint. The other standpoint is the carcinogenic potential, the cancer causing potential of vaping. The combustion leads to the inhalation of various known carcinogens, including formaldehyde, depending on which oils you're using. And so we are very concerned about the airways disease associated with vaping, and then also the carcinogenic potential that goes along with this. People might forget, in 2019, there is this whole thing called EVALI, so electronic, vaping, acute lung injury. And if you remember, multiple reports of people developing acute lung injury requiring ICUs, and in fact, a couple of reports of young folks needing lung transplants and getting lung transplants because of the acute lung injury that took place. And a lot of that noise got drowned out, unfortunately, because something called COVID-19 hit shortly thereafter, and people maybe have forgotten about this. But it was earlier this year, sort of January, February, and I was when I was on inpatients, that we had a person come in who we suspected had this as well, this acute lung injury that goes along with vaping. So very, very concerned about vaping due to its impact on the airways, and people who have underlying lung disease like asthma, and the development of other diseases like COPD, the carcinogenic potential that's associated with or that can be associated with vaping, and then finally the acute lung injury that goes along with it. Like it was a very traumatic experience, to be quite honest with you, taking care of that patient earlier this year. Simply because this person was 19 years of age, and you're just wondering what's going to end up happening with him. And he was in ICU for a long time, required ECMO for support, and ultimately the inflammation settled down. So luckily, we didn't need to transplant him, and he survived the ICU. But he's left with chronic lung disease at 19 years of age, and it's not the long term for him is going to be challenging.
Dr. Bhutani, before our break, you talked through the non-pharmacological and pharmacological treatments thoroughly with us, and we're hearing more and more about targeted treatments, specifically biologics and their application in COPD. Can you help us understand how biologic therapy is working in COPD?
Yes, so that's probably the most topical question right now when it comes to the role of treatment, what options we have for treatment within COPD. So as we said before, inhaled therapies are sort of the cornerstone therapies, and in our guidelines, once you get to what's affectionately known as single inhaler triple therapy, where you have the three different molecules that we've known to provide the best outcomes for patients with COPD, combined together in a single inhaler. If patients continue to have symptoms or have flare-ups associated with their COPD, the question is, what else can we do? And historically, we've added in oral therapies. So we've used a macrolide antibiotic, either daily dose or 3 times per week, or we've used an oral medication called roflumilast, which blocks a specific pathway of inflammation within the lung. That medication, although very valuable, is a very hard medication to take, and a lot of patients are unfortunately unable to tolerate it. So that becomes a bit of a challenge of using that medication. And then there's some oral anti-inflammatory medications called N-acetylcysteine, or NAC. And again, the data on NAC in our last guideline was not as robust as we'd wanted to have. So there was very limited options once you had people on modern day inhaled therapies and they continue to flare up and have exacerbations. What are the other options? So as science goes, and this is one of the interesting things about medicine is the lifelong learning. You see that although COPD is historically been called a neutrophilic inflammatory lung disease, we do recognize that there's a proportion of patients who have another cell type called the eosinophil that is part of their inflammatory process in their lungs. And so, the concept was that we have these excellent medications in asthma, these biologics, which target various, immune cells within the airway that have been very transformative within the asthma population, that have really changed the way that we approach therapy within asthma. If there's a proportion of patients who also have this eosinophil being part of the process of disease development or aggravation, well, perhaps those biologics from asthma could be used within COPD. And so when we talk about targeted therapies, these biologics that we speak of are targeted to inhibit or block various immune cells. So you've got a number of the ones that are out there that target what's called the alarmins. So there's the TSLP inhibitors. You have inhibitors of IL-5 and IL-5 receptors, and then you have the IL-4 inhibitor. And so all those molecules, all those drugs targeting those molecules have been studied. And so the ones that are going to come to Canada almost imminently are the IL-4 inhibitor dupilumab and the IL-5 blocker mepolizumab. Those two they're currently in review by Health Canada and will likely be available in the next few months for use in Canada. They're already approved in the United States and in Europe, and so they're going through the processes to make these medications available here. It is a bit of a nuanced area because there's a very specific phenotype of patients with COPD who would be eligible or who were in the studies that showed benefit. So those are patients that had recurrent exacerbations, had chronic bronchitis, and had their eosinophil level above 300. So it's a very specific phenotype. So it'll be interesting to see what the indications are for dupilumab and mepolizumab once Health Canada gives them their indication. I should say that mepolizumab was studied in a more generalized population of patients with COPD. So it'll be interesting to see what the difference is in terms of the criteria that needs to be met to get them. They're very exciting. There's no question about it. But there's other targeted therapies like this molecule called benralizumab, which is very effective in asthma, was studied in COPD, and the results were just presented, or were just high-level results were just released, and unfortunately, it was a negative study. So the Resolute study did not show a benefit of benralizumab. And then there's other molecules targeting IL-33 that have had mixed results. And so the use of biologics is new in COPD. What's good is that we have familiarity with these biologics from the asthma space. And so the safety and tolerability, I think we're very comfortable with. So once they get approved, if we can find the right patient who would qualify for these medications, I think they'll be very helpful. But it's interesting that, that different molecules are not providing as robust of results as, say, dupilumab or mepolizumab.
The science in this space has been evolving so quickly, and it's so fascinating to us to hear the updates and what's coming down the road. The biologics are amazing. So this might be a really difficult question to answer, but I want to ask it anyway. As a lung health expert, how do you determine which biologic, with all the options out there, is the right fit for a patient?
Right. I think earlier I said there's the $1 million question. This is probably the $100 million question, and that's to be determined. To be honest, Laurie, I mean, I think I think a lot of this will depend upon what Health Canada provides for an indication for the medication. So, what's the labeling that Health Canada suggests, where you can use it and which population can use it? If the populations are completely overlapped, that creates a bit of a challenge, and I'll get to that in a second. If there's separating criterion, then perhaps you can find the patients that would match the most appropriate therapy. I think we're in early days right now when it comes to the use of biologics in this patient population, and just like it is with asthma, there's not a tremendous amount of clarity in terms of what patients should be using, in which biologic to be using for which type of asthma. I think there's a lot of overlap, and I think what will factor into it is your comfortableness with the medication. Two, it'll be the effectiveness of the medication. Three, as we say in our guidelines, and really in everyday practice, it's shared decision making, going through the evidence with your patients and saying, okay, well, this is what we think is happening here. This is what happens with this medication, and then going through the pros and cons of the medications themselves, and it be part of shared decision making. What's exciting about having the biologics available is that there's a lot of science that needs to be unearthed, and I think getting patients on treatment, following the response, entering these patients into large registries where we can get large number of patients who have been treated with the medication under one umbrella, to understand, is there a particular patient population that is more likely to benefit versus the other. Once you start using this in real practice, I think that's really important. So I'm a big advocate of following patients on biologics in registries, because the randomized trials that get these drugs approved give us a bit of information, but when you're face to face with a patient across your desk and asking them, where do you go when you got overlapping criterion, it is a challenging discussion to have, but it's a discussion that needs to be done with your patient as their partner, and that brings us back to the whole concept of self-management. They need to understand what the disease is, and they need to be your partner in terms of helping you make the best decision for them.
Earlier, when you talked about biologic therapy in context with asthma and lessons learned about tolerability and the right biologic for the right fit and for the right phenotype, in terms of COPD, do we see that if once on a biologic therapy, always on a biologic therapy? Is it a lifetime treatment? And part two to that is it ever a case where there's a patient on more than one biologic at the same time?
Yeah, that's a really good question. So this is probably the most salient question that our patients ask us is, once I start, am I on this forever? Right? Do I need a needle every 2 weeks or every month or every other month? And the reality of it is what first, I mean, the first question really is it working? Are you getting the response that you were expecting in that patient? And so for patients within the COPD space, we're looking at reducing the frequency of their exacerbations. And so you look at the randomized trials and you say, okay, well, we're looking at around a 30% reduction in the exacerbation rate in the following year. So if you've achieved that goal, then I think, yes, then you've got to go on and then you continue on with it. And the question becomes that's where the registries will be helpful to know, is there a plateauing of the effect? Is it a continual effect? I mean, these are early days to know to answer that question. There's some real world evidence that's being generated by the companies that have developed these medications to make sure that the effect in the randomized trial is maintained over the long term. But we are in early days for that. So I think the first question, if a patient was to ask that, and to answer your question, is, are you getting the Are you getting the response that you're looking for that asked you, as to why you started the medication in the first place? The long-term safety of the medications is fairly sound. I mean, we've had 15 plus years of experience with the biologics in asthma, and really, I don't think there's any reason for concern in the COPD population. But that needs to be teased out. Right? Our COPD patients are different than our asthmatic patients, so following these patients again in a registered and observed way will help us understand if there's any safety signals that come over the long term. But if you're getting the effect, I think we need to sort of think like the cardiologists do, is that once you put people on therapy, you really want to just keep them on the therapy, because coming off the therapy may not be beneficial for your patient.
We're so curious to hear your thoughts on this next comment. So we've had a few previous episodes where we've talked about asthma and the concept of remission. Now, we're starting to hear from our communities about remission, or they're using the word remission in COPD. Is that something, Dr. Bhutani, that you're truly seeing, or is that just hopeful thinking?
Right. Yeah. So the concept of remission is a very interesting one. I think that in the asthma world, it's really taken flight. In COPD, just because the biologics are coming in, the question is it are we able to achieve a similar viewpoint of this, which is zero exacerbations, preservation of lung function, those sorts of things. Can we achieve that in COPD? And I think it's a great North Star to probably go towards, and sort of I think that's the hope for everyone, is to sort of create that viewpoint. But there's, just as we come to understand COPD more and more, there's a lot of heterogeneity in the COPD population. I'd say that the number of phenotypes of COPD, and endotypes is another term that we are starting to use in the COPD literature, is quite broad. So although I think we should have high aspirations in terms of reaching for remission, I think that's early days to see if we can achieve that in COPD. But that should be a North Star that we try to aim towards. Another concept that's being floated around is disease stability in COPD, and maybe that's something that is a bit more realistic in the next 5 to 10 years, to sort of say, well, can all these interventions, the non-pharmacological and the pharmacological, can come together? Can we just keep them where they are? Because unlike asthma, where lung function is recoverable, in COPD, as you know, that once the damage is done, the damage is done. You can't recover that lung function. So maybe remission, instead of remission, maybe disease stability might be the one concept that we should maybe trying to aim towards when it comes to COPD. And I think there's some sort of momentum behind that concept as well. Looking at the fact that patients don't lose any more lung function, that they don't exacerbate anymore, and that they have a stable functional status and quality of life. So I think that's certainly, although that's the term that's come out now, and I think it's a very reasonable term. I think that's, as a clinician and as a practitioner in this space, that's the one thing that I've always sort of tried to achieve within my own patients, is to sort of make sure they don't lose any lung function. Do the smoking cessation, do all those other things that are necessary, that are important to preserve where they are right now.
Well, Dr. Bhutani, you've certainly framed that remission theme for us very optimistically, and we are getting close to the end of our time with you, and we want you to look on the horizon for us and kind of tell us a little bit what you think the future holds and what you maybe are the most excited about in COPD research.
Yeah, I think there's a few things that I'm really excited about. One is the concept of cardiopulmonary risk in COPD. So this is an area that I've been involved in for many years, and the concept of how the lung disease affects the cardiac outcomes has really taken gained a lot of momentum here in the last few years. Myself and a colleague out of Leeds, UK, is a cardiologist named Chris Gale, and along with David Price, who people may know as an important facilitator of knowledge within the asthma space, who runs the International Severe Asthma Registry. The three of us have formed something called the International Cardiovascular and Respiratory Alliance. So this is a global working group trying to further understand the use or the relationship between COPD and cardiovascular disease. So we're starting off within COPD because it's very topical, but the relationship with the heart and lungs certainly extends to all pulmonary diseases. And so we're very excited. We have a steering committee, and we have about 165 plus members from around the world. And it's really a global working group to try to understand the cardiopulmonary interaction. So I'm very excited about that. A bit of knowledge that's going to come from this group. There's a number of important medications that are being studied in phase 1, phase 2 studies. I think some of these are very, very exciting, and it's pushing the envelope of our understanding of inflammation within the lungs. And although they're early days on phase 1, phase 2 studies, if they actually can demonstrate benefit, they're novel molecules. Importantly, some of them are oral molecules. I mean, that's been the holy grail within airways disease, is to find something that you can take as a pill versus an inhaler. That's really kind of important there as well. And then to a question that was asked earlier is combination therapy, these biologics, useful? Yeah, there's some studies that are being performed, some nanotechnology studies looking at combination of these biologics and through nanotechnology, looking at whether they're effective or not. And so the horizon is very, 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 very important, or sorry, very, very exciting. And lastly, I'll just speak to the role of medical imaging. I think one of the things that we have sort of undervalued is the role of medical imaging in airways disease and in COPD. A colleague and a friend from Western Ontario, Dr. Grace Braga, is an international leader who's helping push the envelope as it relates to our understanding of the use of medical imaging within COPD. And I think I'm very excited about what that information can come from that diagnostic test. So there's a lot of fun to be had in COPD over the next 10 to 15 years for sure.
Dr. Bhutani, your energy and your excitement and your passion always shines through. And we just want to thank you so much for being with us here today. You are a true North Star in research and clinical care in COPD and education, and you have helped us make a real difference in the lives of the people we support here in Saskatchewan, and you certainly make a difference internationally. So we're so grateful for your time today. And even though we always say we really miss you in Saskatchewan, you're always welcome back to the family table anytime. So thank you again for taking time to talk to us today on Let's Talk Lungs.
Thank you very much, Lori. I always appreciate it. And as I say, I truly value and enjoy the relationship we have got with everyone there in Saskatchewan, especially the both of you and the important work that you lead.
Thanks for listening. If you enjoyed this episode and you'd like to help support LungSask's Let's Talk Lungs podcast, please share it with others. Post about it on social media. Like, subscribe, hit that notification bell for new episodes, and leave us a review. Follow LungSask on Instagram @LungSask and on X @LungSask. That's all for this episode. See you next time.
Produced at
Sound Lounge by T-Bone.